cardiac imaging techniques, including cardiac MRI, CT angiography, and CT MRI for congenital heart diseases. He has authored multiple chapters for books and has more than 15 publications in peer-reviewed journal in his credit. He is an executive committee member of Indian Association of Cardiac Imaging and member of European Society of Cardiology. I invite him to share his insight on imaging anatomy of heart and coronary arteries. Welcome, Dr. Audi, sir, all the way from the Pune. The Omkar is a 2005 batch student from NIAD. So welcome him.
Thank you, ma'am, for the kind introduction. Good afternoon, everyone. Good afternoon, everyone. Okay, thank you for waking me up, because it's quite hard, to deliver the lecture in the post-lunch period. So I'll try my best to not bore you and share some interesting details over here. Okay, so we start with the imaging anatomy of the heart. So what we are seeing over here, let's look at the overview of the heart, that you all must know that this is a 4-chamber structure to start with. It's very simple. There are 2 atria and 2 ventricles. Okay, so the atria are the smaller chambers, ventricles are the larger chambers of the heart. So atria acts as a receivers of the blood, and ventricles act as a Okay, so atria acts as a receivers of blood. Either it is from a systemic circulation or a pulmonary circulation. Ventricles acts as a pump of the heart. Okay, so that will pump the blood into this either systemic or the pulmonary circulation. So this is the anatomy topic and why I'm telling about the physiology. But this always go hand in hand. So radiology, if you want to know the radiology, you have to know the anatomy for starters, and you have to know the physiology also along with. Okay, so this is the schematic diagram of the heart, where you can see the larger chambers are the ventricles, the smaller chambers are the atrium. These atrium are the receivers of the blood. Are you able to see my cursor? No. Cursor is not able to see. Okay. I'll do that. Okay. So these are the ventricles, which are the pumping system of the heart, and these are the atria, which are the receivers of the blood. So on the right side, it has a right atrium and the right ventricle. They are connected through the valve, which is called as tricuspid valve. Excellent. So on the left side, it's a left atrium and a left ventricle, which is connected through a valve, which is called as mitral valve. Okay, excellent. So whatever the blood from our systemic circulation, the deoxygenated blood that comes through the superior vena cava from the supex, and from the infex through the inferior vena cava, and they go into the RA. From RA, the blood drains into the RV, and RV gives the blood and pushes the blood into the main pulmonary artery, and in turn in both the lungs to get the blood oxygenated. So once the blood gets oxygenated, it will come through pulmonary veins on either side. So usually there are 4 or more pulmonary veins. There can be at minimum there can be only 2 pulmonary veins, one on the right and one on the left. And they drain the blood into left atrium. So from left atrium, it goes into the left ventricle, and left ventricle pumps the blood into aorta to supply it to the entire body. Clear? So this is how the heart looks in a cadaveric specimen. You must have seen in your dissection on the dissection table. And this is the heart we can reconstruct more or less similar to the real specimen on the CT image. So this is the CT images which are reconstructed into a 3D model, and we can look like this. But other CT images are like this? No, these are just black and white images, right? So once you do the CT, the images will be something like this. Okay. So these are the cross section. We call this as a cross sectional views. So you cut across the body, whatever the part you imagine over there. So this is covering only the heart part, and then you cut across the body cross sectional to the long axis of the body. So that's why whatever images you are seeing, these are in a cross sectional view. This side is the right side, though it is on the left side when you see it. But if you see it from the feet point of view, this is the right side and this is the left side. For any radiological image, when they are presented in a standard format, this is the right side and this is the left side. Okay, so we are now going to see the imaging anatomy of the heart. What we are going to see is first connections. Like I told you, atria are the receivers. They receive the blood from veins. Then it connects to the ventricles, and ventricles are connected to the great vessels like aorta and pulmonary artery. That we call it as a AV and VA concordance. Okay, atrioventricular concordance. So when your right atrium is connected to the right ventricle, that is a good concordance, right? If that doesn't happen, then that's a discordant anatomy. Okay. So when your right atrium is connected to the right ventricle and the left atrium is connected to the left ventricle, it is AV concordance. Okay. Similarly, when your MPA arises from the right ventricle and aorta arises from the left ventricle, so that is VA ventriculo-arterial concordance. Clear? So we are just seeing the connections over here. Then we'll see about the systemic venous drainage. We should make sure that the systemic veins are draining into the IVC and SVC, and then they drain into the RA. The pulmonary venous drainage, it normally drains into the LA, left atrium. Then we see the morphology of chamber. Why we are discussing so much about the right ventricle and left ventricle? If there is a chamber, that's enough, right? But no, there are some characteristics of this chamber which makes them unique or which makes them special to do their own work. So we will see a little bit about the morphology of chambers. And at last, we'll see the coronary artery anatomy. Okay, so for that, I'll have to take you to the actual viewing platform. Okay, so this is the CT image. This is the X-ray-like image. You acquired it first on CT scan. Then you do the plain CT scan just to look at any calcium in the coronary arteries or the normal. Then you push and dye, which is iodinated contrast. And then you do this imaging over here. So this is your CT scan. Okay, so now we'll see the imaging anatomy in detail. So whatever we have studied. Next. So these are the actual images of body, right? So what we are going to do, as you know now the connections and the connections within the heart, and you know how the blood flows within the body. So if you have imagine you have given the you have put on the vein flow in the antecubital vein, and then you have given the iodinated contrast through it. So whatever the iodinated contrast, it looks like a bright as in this image. Okay, so this is a bright contrast that you are seeing. This is the contrast what you are seeing. So just imagine the flow of the blood from the antecubital vein. Okay. So this side is left or right? Left. You are able to see my cursor, right? Okay. So the vein flow is put on the left antecubital vein. So now you can see this bright blush of the contrast over here. Okay. So can you see this blush of contrast? So we'll follow this contrast. Okay. So it goes into from the antecubital vein, it will go into the cephalic and then subclavian vein, right? From the subclavian vein, it goes into the left brachiocephalic vein. So you are seeing here anteriorly left brachiocephalic vein, which joins together with the other side or the right brachiocephalic vein to form SVC, yeah, superior vena cava. So this is your superior vena cava that goes and drains into the right atrium. Okay, so if you follow that right atrium inferiorly, then you will see a IVC over here. Okay, and then this right atrium is connected to which chamber? of the heart? Right ventricle. So this is the right ventricle. You can see the position of this right ventricle, which is anterior. So when you hold the heart specimen in the anatomical position adjacent to the dissection table, you have to hold it in the anatomical position, right? Where you see the right ventricle anteriorly and left ventricle posteriorly. So similarly, this is the right ventricle anteriorly, left ventricle is posterior and left to that. And the posterior most chamber is your left atrium. Okay. So from right ventricle, the blood goes into the pulmonary artery. So this is your main pulmonary artery over here. And this is right pulmonary artery, left pulmonary artery, and then blood is given to the pulmonary circulation. Then again, the heart receives the blood through pulmonary veins. So these are the pulmonary veins over here. This is on the left side, 1 and 2. This is on the right side, 1, 2, and 3. Okay, so there are 5 pulmonary veins in this case, and they are all draining into the posterior most chamber, which is a left atrium. Okay, and the left atrium is connected to left ventricle. And then again, it gives the blood into aorta. Yeah, this is the aorta. So if you see the relationship over here, that the aorta arises posterior to the main pulmonary artery. As you have seen in the specimens, that the main pulmonary artery is the anterior most, and then the aorta arises posterior from it, and then it arches on the left side. Okay, so if this is confusing, we can see this in multiple views. Okay, so if you are not comfortable with the axial scan, you can see in sagittal scan over here, or you can see in coronal scan over here. Okay, so if you see in a physiological point of view, then your relations, if there is an anomalous pulmonary venous connection, then you will come to know when, if you follow this, stepwise manner, if you see the CT scan. If you just see the random images, then you will certainly miss most of the prominent anomalies. Okay, so I can rotate this image in whatever way I can. You can see that as I'm rotating the axis, the image is getting rotated. So I can see the aorta in full picture over here, arising from the left ventricle on this side. On this side, I can see the aorta in other views. So here is the right atrium and the right ventricle I can see in other views. Okay, so what is the main advantage of its CT scanner? That it's a volumetric image. So you can rotate around the image, you can play around it, you can make some 3D recons, you can make some MPRs or MIP reconstructions over here, and you can see anatomy in very much detail. Okay, coming back to our presentation. Okay, so now we have established the connections. Now we'll see the morphology of certain chambers. So how to differentiate the right atrium from the left atrium? So what is the difference between the two anatomical differences? First of all, the right atrium is connected and receives the blood from SVC and IVC. Okay. Similarly, left atrium receives blood from lungs. Okay. So when you are assessing, let's say, abnormal anatomies, and there is, not a proper, or there is abnormal systemic venous connection, there is abnormal pulmonary venous connection, how to identify which is the right atrium and left ventricle? The answer is in the appendage of the ventricle. Okay. So atrium. So each atrium has an appendage, which is also called as the auricle or appendage. Okay. So if you see at the right atrium, the appendage is triangular. It is broad-based. So appendage is triangular and it is broad-based over here. This is the right atrial appendage. On the other hand, the left atrium has a finger-like appendage with a pointed tip. Okay, so usually it covers the left circumflex coronary artery anteriorly. So this is the main difference between the two atria according to the morphology. Okay, next, there is something called as the crista terminalis over here. Okay, so the crista terminalis is a ridge it connects the IVC and SVC junction with the RA. Okay, so it's a fold of tissue between IVC, SVC, and the RA. So it runs through the entire length, and you can see like this as a mass. So why this is very important to know, that sometimes on echocardiography you will see that either is this a mass lesion, or is this a thrombus, or is this normal structure, because the crista terminalis is not present in all the individuals, right? So crista terminalis is an anatomical variant which runs posteriorly. So it is very important to know, if you are seeing any mass lesion or thrombus-like lesion in this part, it is a crista terminalis. Okay. Similarly, on the left atrium, it is a Comodin ridge, which is again fold of tissue. It's an embryological remnant in the left atrium, which is adjacent to the left superior pulmonary vein. Can you see over here that the fold of a tissue over there? Again, it should not be confused with any mass lesion or thrombus in here. And thirdly, the coronary sinus eventually drains into the right atrium. What is coronary sinus? That all the coronary arteries supply the blood to the LV and the heart, and coronary veins, they drain the blood supply from the heart, and then they drain into the coronary sinus. So that coronary sinus is eventually connected with the right atrium. Okay. Similarly, the differences between the right ventricle and the left ventricle, as we know that the right ventricle receives the blood from RA. So now this is the reconstructed CT image that I showed you that you can reconstruct in any manner. So this is the same patient what we saw, and I have reconstructed the images in the manner to learn the anatomy, where here the right atrium is connected to the right ventricle, and then the MPA is arising from right ventricle, right? Similarly, on the left side, left atrium is connected to left ventricle, and aorta is arising from left ventricle over here. So if you see the differences between the two, the right ventricle is a thinned wall structure, okay, and the left ventricle is a thick wall structure. So why it is made like this? Because left ventricle has to supply the blood to the entire body, right? That's why your left-sided pressures are more. The right ventricle has to supply the blood only to the lungs, nothing else. That's why your pressure system on the right side is low. Okay. So that's why the muscles of the left ventricle are the thick muscles, and the muscles of right ventricle are thin muscles. But let's say there is a pulmonary stenosis over there, and so what is pulmonary stenosis does? That it is an obstruction to the blood flow. So in that cases, you might have a RV hypertrophy as well. Okay. So how to identify a right ventricle in that scenario is presence of moderator band. Okay. So moderator band is a structure which is a muscular structure, and it connects the septum on the RV side to the RV free wall. Can you see the structure over here? That's a moderator band, and it is the characteristic of right ventricle. If you are seeing a moderator band in any of the cardiac chamber, that's a right ventricular cavity. Okay. And if you see, this is the short axis view of your ventricles. You are seeing that on the LV side, this is LV, this is RV. And on the LV side, you are seeing that the septum is smooth. Okay. And now you can see the septum over here. It's not very smooth. So there are multiple trabeculations over here. Okay. So the septum on the LV side, interventricular septum, is smoother. And on the RV side, it is with the multiple trabeculae. On the LV, you are having these two prominent papillary muscles, okay, which are predominantly on the lateral wall. This is called as the anterolateral, and this is called as the posterior or inferior papillary muscles. So there are two prominent papillary muscles. On the other hand, in the RV, there are smaller papillary muscles. There are 3 papillary muscles, but this will not be like a bunch or not like a hypertrophied papillary muscles over here. And papillary muscles connect to chorda tendineae. Chorda tendineae connects to the mitral valve and tricuspid valve, respectively. Okay, excellent. Okay, so as we see that there is a atrioventricular valves, which are tricuspid valve on the right side and the mitral valve on the left side. Then there is a pulmonary valve at the origin of MPA and aortic valve at the origin of aorta. Okay. So there are 4 valve structure. Out of that, only mitral valve has a 2 cusps. Okay, the rest of the other valves, normal anatomical, there are 3 cusps. Okay, so there are 3 cusps in aortic valve. There are 3 cusps in pulmonary and tricuspid valve, and in 2 cusps in mitral valve. Okay, so if you cut across this aortic valve over here, you are seeing this like a Mercedes sign. Can you see that? Okay, so these are the 3 cusps of aortic valve. That also you can see in much more detail. The posterior most cusp, which is adjacent to these are the atria, okay, left atrium and the right atrium. So the cusp which is adjacent to the interatrial septum, that will be a non-coronary cusp. Okay, and then anterior to that will be right coronary cusp, and this will be a left coronary cusp. So there are 3 cusps in the aortic valve. The nomenclature is based on the posterior most adjacent to the interatrial septum will be named as a non-coronary cusp, and then right and left coronary cusp. Okay. So this is the different pathological aortic valve where you are seeing a lot of calcium. The bright thing is the calcium over here. You are seeing that these 2 cusps are fused with the calcium over here, correct? And this is a functionally bicuspid valve. So though this is a tricuspid valve, you can see that the 2 cusps are fused together and they will act as a single unit over here. And then this becomes a functionally bicuspid valve. So this is a big chunk of calcium in the central central zone of the cusps over here. So why I'm telling you this, that the imaging is so advanced now, especially the CT imaging, that has to be performed before doing any TAVR procedure. Okay, so the TAVR is something called as, you must have heard about the aortic valve replacement, right? It is surgically when you cut upon the sternum, you cut open the aortic valve, you chuck out the old valve, and then you place the new valve over there, and then you are good to go. So that's your surgical AVR or surgical AV replacement. Now it's a era of TAVR, which is a transcatheter aortic valve replacement. So you just put a catheter through your femorals, and then you reach the heart, and you just open the valve over there, and then that's done. There is no need to undergo the sternotomy and the entire surgical operation for that. And for that reason, the CT is mandatory before doing the TAVI to size it accurately, because you cannot go wrong over here. So if the valve is not perfect, if the valve is too small, then it will act as aortic stenosis. If the valve is too big, then there will be aortic regurgitation. So there will be a lot of complications. So your sizing has to be accurate. For that, you have to undergo CT angiography before any procedures like TAVR and TAMVR. And for that, you need to learn about the anatomy in detail about the valves. Okay. So what is the importance of anatomy? Why we are so much stressing about the anatomy in this modern medicine? First of all, what are the importance of connections? So as I told you how to look for the systemic veins and how they are draining, if they are anomalous, there can be bilateral SVCs. So very simple example of that. Let's say there are bilateral SVCs. One is going into the right atrium, other is draining into the coronary sinus and going into the right atrium again. So there is no shunt, but when the patient is admitted for some other reasons in ICU, and you put up the central line on the left side, it will not give you the accurate right atrial pressure measurements. Okay. So again, if you find this is not a lethal anatomy, but if you find this, you need to report this so that the management of the patient will be better. Again, there are some other anomalies like interruption of IVC, duplication of IVC, which you can pick up when you see the systemic veins. When you see the pulmonary veins, you can pick up anomalous pulmonary venous drainage, which can be PAPVC, partial anomalous pulmonary venous drainage, or TAPVC, which is a total anomalous pulmonary venous drainage. The obstructed TAPVC is rather a neonatal surgical emergency where you have to make decisions very fast within hours. So I told you about AV and VA concordance. There are multiple defects associated with this, which is tricuspid atresia or double inlet LV or double outlet RV. So double outlet RVs, aorta and pulmonary both are arising from the right ventricle. So if you are not thorough with the anatomy, you will not be able to make this diagnosis. So like there is a transposition of great arteries. The MPA is arising from LV and aorta is arising from RV. So that is a transposition of great arteries. So what is the importance of morphology? So when you are, I told you that the mass mimics like crista terminalis and Cowmedin ridge that you should be aware of and not call it as a thrombus or mass lesion. In heterotaxis syndrome or complex congenital heart diseases, again, it's very important to, name that chamber, whether it's a morphological RV chamber or morphological LV chamber. That makes a lot of difference in the patient management. The other form is corrected TGA. So what is corrected TGA? I'll just take 1 minute on this. So corrected, as you have understood the AV and VA concordance, right? Okay, let's look at the AV discordant. What is AV discordant? If your right atrium is connected to left ventricle, okay, and the left atrium connected to the right ventricle, okay. In corrected TGA, the AV discordance is there, as well as there is a VA discordance. Okay, so what is VA discordant? That the aorta is arising from right ventricle and MPA is arising from left ventricle. So in corrected TGA, if you see the blood flow wise, the deoxygenated blood goes to the pulmonary artery, oxygenated blood goes to the systemic veins. There is no difference, correct? But what happens that there is change in the ventricles. The ventricles only they have changed the position. The right ventricle has come to the left side and the left ventricle has come on the right side. That's the only change. So this particular anatomy, and as your right ventricle is giving the blood to the systemic arteries, it is already hypertrophied. Okay, so you will not be able to make a diagnosis on the basis of muscle thickness only. So you have to know that there is a moderator band over here, and this is a morphological right ventricle, and this is a morphological left ventricle. So what happens in this patient? In this patient, there is no left to right shunt or right to left shunt or no shunt over there, no cyanosis or anything. But over a period of time, the right ventricle will not sustain the systemic pressure. Okay, so you have to act early in these cases. So these cases, mostly they present in their late 30s or late 40s. Okay, so if you diagnose it early, then the management will be much better. Okay, and as I told you, there are multiple, like TAVR, there is TAMVR also. You can replace the mitral valve through the catheter. You can replace the pulmonary valve through the catheter. So all these newer techniques, they need a good CT coronary, CT angiography reports in there for the accurate sizing of the valves. Okay, let's look at the coronary anatomy. Okay, to look at the coronary artery, we have to know aortic root anatomy in detail. So we know that now aorta is arising from left ventricle. Aortic valve is a tricuspid structure. Okay, there are 3 cusps in there. So your aortic root is the part where your aorta takes off. Okay, so the junction of aorta and the left ventricle is called as the aortic annulus. Okay, and this bulging part over here, these are called as the sinus of Valsalva. Okay, and the junction between, this is the ascending aorta. So the junction between ascending aorta and this aortic root is called as the sinotubular junction or ST junction. Okay, so there are 3 parts of aortic root: annulus, junction with the LV, sinuses, the middle bulging out part, and the ST junction, which connects to the ascending aorta. Okay, so this is your pulmonary annulus. This is sinus of Valsalva. This is an ST junction. Clear? Okay, excellent. So as we know that we can cut across any plane in CT scan. So let's cut across the pulmonary valves. So what you are seeing over here, that 3 cusps are there. So the posterior-most cusp, which is closer to the interarterial septum, is your non-coronary cusp. And then the anterior one is right, and on the left side, it's a left coronary cusp. So if you cut across little more above the, at the level of sinuses, you will see the origin of coronary arteries from here. Okay. So the right coronary cusp gives off the right coronary artery. The left coronary cusp gives off the left coronary artery. Clear? Okay. Let's again look at the radiological picture over here. I'll just close this. Okay, so this is very important that you have a three cusps and right coronary artery arises from the right side and the left coronary artery arises from the left side. But you must have heard that there are three coronary arteries in the heart, right? So the left coronary artery divides into the two, which is LAD, left anterior descending coronary artery, and the LCX, which is the left circumflex coronary artery. Let's look at this one. So I'm just scrolling through the images over here. Okay, so this is your left coronary artery arising from the left coronary sinus. Then it divides into the LAD over here, which is a left anterior descending coronary artery. So if you just follow the LAD, just follow this thread over here. So this is your left anterior descending coronary artery, LAD. It goes into the interventricular groove. Anterior interventricular groove. So these are two ventricles, right ventricle and left ventricle. So the groove in there is called as the anterior interventricular groove. And the LAD travels in that groove. Okay, so I'll say in other words, so the coronary artery which is arising from the left coronary sinus is not a left coronary artery, but the coronary artery which goes or which travels into the anterior interventricular groove is your left anterior descending coronary artery. Okay, that's why it is called as the anterior descending, because it's in the anterior interventricular groove. Okay, similarly, the LCX or the circumflex coronary artery, which goes into the left atrioventricular groove. Okay, so that's your LCX. And your RCA or the right coronary artery goes into the right atrioventricular groove. Clear? Okay. So again, these coronary arteries, you can see in multiple planes, you can turn around and you can see in the entire thing. So if I want to show you the entire course of it. Okay. So these are the 3D reconstructions of the same patient, where this is the left coronary artery, left main coronary artery, which divides into the LAD, which goes into the anterior interventricular groove, and the LCX or the circumflex, which goes into the left atrioventricular groove. Okay. So the branches arising from the LAD, these are the diagonal branches on the lateral aspect, and the septal branches, these are the septal branches over here, which goes into the myocardium. Okay. Similarly, the LCX has obtuse marginal or OM branches. Okay. So LCX gives off the obtuse marginal or OM branches. Okay. Okay. And this is your RCA or right coronary artery, which goes into the right atrioventricular groove, which further goes down and divides into the PDA or posterior descending coronary artery, which runs into the inferior interventricular. Oh, okay. So there is an anterior interventricular groove, and then there is a posterior or inferior interventricular groove. So the PDA runs into the inferior interventricular groove, and this is the PLV, which is a posterolateral ventricular branch. Okay. So this is how the entire circle is formed. So this is your RCA, this is your LAD, this is your LCX. So this gives, this called as a circle and half loop model. This gives the blood supply to the entire heart from all the sides. Okay, so what is left coronary artery or what is the right coronary artery? Is not the coronary artery which arises from the right side always, but where it runs into the right atrioventricular groove, it becomes a right coronary artery. Okay, and the LAD LED goes into the anterior interventricular groove. Okay. So this PDA is a little special branch, so which runs into the inferior interventricular groove. So sometimes it comes from the right side, RCA, or sometimes it's come from the circumflex side. Okay. So when it comes from the right side, we call it as a right dominant circulation. When it comes from the left side, we call this as a left dominant circulation. So more than 70% of the people, they have a right dominant circulation. Around 18-20% people, they have left dominant circulation, and around 5% population will have co-dominant circulation. Okay. So this dominance, the decision of the dominance is based upon the PDA arises from where, right? Okay. And as I told you, the course of coronary artery determines the nomenclature. We have seen the diagonals and the septal branches of the LAD, and the branches arising from L6 are called as the obtuse marginal branches. Okay. So why I was saying that the course is really important, that these are some schematic images of the coronary artery anomalies, where here you are seeing that your left coronary artery arising from the right cusp. Here your right coronary artery arising from the left cusp. Okay, so the origins can differ in anomalous cases, but they follow the same path. So if it travels into the right atrioventricular groove, that is your RCA. Okay. Sometimes the coronary artery also can arise from pulmonary artery. That is called as the AL kappa. Okay, not going much into the details of it. So this is one aspect of your coronary angiography to assess the anomalous courses. The most important aspect of the coronary angiography is to assess the stenosis or blockages in the coronary artery, which are responsible for the heart attack and sudden cardiac death, right? So these are the different tools we have at our workstation, which includes a 3D model. This is called as the MPR view, where you can see from start to end. This is the LED picture over here. Start to end, you can see the straighten view, you can see the cross-sectional view, so as we can determine if there are presence of any plaques, which is a soft plaque or calcified plaque, and how much obstruction, how much stenosis it is causing to that vessel. So CT angiography, again, this is a non-invasive investigation. It's an OPD investigation. There is no need to admit the patient. With the newer CT scanners, we can do at any heart rate up to 120. So it's literally walk-in test for anybody. You can finish the test in 10-15 minutes, and you can have these lovely images with you, and you will have the entire data of your coronary artery blockages or stenosis in there. Clear? So CT, we do. What are the indications of CT? One, we saw that in congenital heart diseases, to define the anatomy, to define the morphology of chambers, to define the connections, to define the shunts. Okay, that is for the congenital heart disease. For the adult one, to assess the coronary artery disease, to assess the coronary artery anomalies in detail. So these are the two prominent features of CT scan. Now we move on to the cardiac MR anatomy. Okay, so MR is little different technology where the images are taken by exploiting the magnetic properties in our body. Okay, so it is not volumetric images like CT. Like CT, you have seen that just one data is there. You can manipulate it, you can rotate it, you can do whatever you want to do. On MR, it is a multi-planar imaging. You can take images in any plane, but you have to do it on the machine itself when the patient is in the magnet. Whereas on the CT scan, you do the CT scan and you can assess the images whenever you want to, right? On MR, when the patient is within the MR gantry, you have to take images at that point only, right? Okay, so this is how a typical MR study will look like. There are so many sequences. In CT, you just saw that one plane phase and one iodinated contrast phase. That's it. But here there are too many sequences. Maybe the images are less in here, but too many sequences to handle. Not again going into much into detail. So these are just as we saw the anatomy of the heart at various axial planes. Similarly, we can see on MR. This is the black blood images where you can see your structures, like these are 4 chambers, the RVOT, LV, and the pulmonary arteries over here. So this is the 2-chamber view. So why we have to, again, what I told you, that you have to take the images in there, and you cannot, acquire from top to bottom everything. You cannot manipulate it later on. So that's why there are some structures or some views defined. So these views correlate with your echocardiography views. Okay, so you take the planes in certain angle so that you can acquire the images in that specified time with you. So this is called as the two-chamber view. So we can call this as an applied anatomy. Okay, so this is a two-chamber view in here where you are seeing the left atrium and the left ventricle. Okay, so these are the cine images where you are seeing the left atrium and this is the left ventricle. Can anyone tell what this is? You are seeing this little structure over here. Are you able to see that small little structure going in front, which is a characteristic of left atrium? Yes, excellent. So this is a left atrial auricle. You can see that it is finger-like and it is pointed, right? Okay, similarly, this is a four-chamber view. Again, it's very simple. Why this is called as four-chamber view? Because you are seeing four chambers over here. So there are two atrias. This is the left side, left atrium, right ventricle, and the left ventricle. Okay, so these are four chambers over here. And the wall between two ventricles is called as the interventricular septum. The wall between two atrium is called as the interatrial septum. Simple. Okay, so here you can assess the function of right ventricle and the left ventricle as well. Can somebody tell that what is this structure over here, which I'm pointing out? You are seeing some muscular like bands over there. Moderator band. Okay, excellent. So this is a moderator band which runs from the RV side of the septum to the pre-wall. Okay. So this is the short axis image. When you cut across both the ventricles, you will get this image. Okay. So in this image, this is the LV and this is the RV. Again, the wall in between the both ventricle is called as the interventricular septum. Can somebody tell what are these structures over here? These 2 points. Papillary muscles. Yes, as we saw on that CT image, that there are two prominent bulky papillary muscles in the LV. Okay, so this is a three-chamber view. Why it is called three-chamber? We are seeing three chambers, third chamber as being aorta. Okay, so this is LA, this is LV, and this is the aorta arising from that. Okay, in this way, you can see the function of mitral valve over here. If there is a mitral stenosis or mitral regurgitation, you can assess that also. You can, on MR, you can assess LV function in the sense what is the volume of LV, what is the stroke volume of LV, what is the end systolic volume in the LV. That entire thing you can assess on the cardiac MR. Plus, if there is a mitral regurgitation, you can also assess that how much ml of MR or mitral regurgitation it is going into the LA. Okay, so that is called as the regurgitation fraction. Similarly, if there is AR, you can assess the regurgitation fraction of AR. Okay, so this is a mitral valve and this is an aortic valve in between. So this is again LVOT view in a different aspect where you are seeing the LV and the aorta arising from LV. So these are the standard views we take in cardiac MR because we cannot take the cine images for the entire plane. So this is the RVOT view where you are seeing the MPA arising from RV over here. Yeah. So why this is a RV and why this is not LV? Look at the wall, the moderator band you are not able to see over here because this is not in that. But if you see that wall is thin, it's not thick wall. Again, this is anteriorly located. Okay, so the anterior most chamber is your RV. Okay. And this the valve between it is pulmonary valve. Okay, so there are lots of other images of MR that we need to assess. We can assess the infarction, infiltration. So main MR, why we do it? To assess the myocardium status, to characterize the myocardium. So let's say there is a coronary artery disease that we have assessed on CT, and the patient had MI So we don't know what is the effect of that coronary artery disease. So effect of that we assess on MR in terms of infarction. We can see that which wall is the affected by infarction and which is not. Okay. So for that, to have, um, to have a better understanding at it, there is something called as the 17 segment model of the heart. Again, these are not anatomical planes. These are made by us for us to categorize the LV much, much better. So left ventricle is divided into the basal cavity, which is more towards the mitral valve. Okay. The mid portion of the cavity is mid cavity. The more towards the apex we go, that is the apical cavity. Okay. And the terminal portion is the apex. Okay, clear? So we are taking a representation of this mid cavity over here and apical cavity over here. You draw the line from the RV insertion point. So this is the RV. This is superior RV insertion point. This is inferior RV insertion point. You just draw two lines from there, imaginary lines, and then you will divide this entire LV into 4 walls. Okay. So the superior most wall is called as the anterior wall. The septum is called as the septum. The posterior or inferior is called as the inferior wall, and the other wall is called as the lateral wall. Okay, so this divides into the lateral wall. But if you see, this is the basal and mid cavity. If you see that this segment is too large a segment, right? So you just cut across and put an imaginary horizontal line through it, and then it is further dividing into the other segments, which this is called as the anteroseptal, because this is anterior wall, this is the septal. Similarly, inferoseptal, very simple, inferolateral and anterolateral. Okay, so the 6 segments in basal cavity, 6 segments in mid cavity, 4 segments in apical cavity, that is 16, right? And 17 segment is your apex. So this is again an anatomy which is not there per se. If you take out this specimen cadaveric heart over there, you will not find these segments. But this we have made for ourselves to make our life easier and convenient. Okay, so take home points. Well, it is very important to know the cardiac anatomy. If you are reporting cardiac MRs or CT, you need to know about the connections. You need to know about the morphology. The coronary artery nomenclature, again, it depends on where the coronary artery courses or where it travels, not on the origin of coronary artery. The dominance is determined by the posterior descending artery, whether it's arising from the right, left, or both the vessels are giving the PDA. The coronary artery anatomy is really important in assessing coronary artery anomalies. The cardiac MR has a different anatomical model. There are certain particular views that we take to assess the cardiac MR, and 17 segment model is that we have constructed for our sake of convenience. Thank you. Any questions?
We are starting our next session in next 5 minutes because we are switching the computer. So please hold on.
Audio, slideshow. Yeah, case of an.
Right, sir.
Keep it this here on the side.
एक मिनट.
Okay.
That's all.
इसको नीचे लेके आ सकते हैं
इसको
इसको
जस्ट ड्रैग करके स्क्रीन को ये ब्लैक स्क्रीन.
यस पुट इट डाउन
Good afternoon, everyone. I am Dr. Vivek Ingmire, Assistant Professor in the Department of Anatomy. I would like to introduce you to our next speaker, and this is the last session of our today's webinar. Dr. Rahul Vakharia sir is currently working as Senior Consultant Radiologist at Sir H.N. Reliance Hospital, Mumbai. Sir has 25 plus years experience in the field. He is interested especially in neuroradiology. He has multiple publications, national and international, in his name. Also, sir has done short fellowship at SickKids Hospital, Toronto, Canada. Today, sir is going to enlighten us regarding the magnetic resonance of the neuroanatomy of hippocampus and the limbic system. Please give a warm welcome to Dr. Rahul.
Thank you. Can you hear me? Okay. Thank you. Good afternoon, everybody. And after a very good lecture from of the heart, we'll move to the brain, which gives the order to for the people to function, right? So sorry, at 3 p.m. taking a lecture on anatomy of hippocampus and limbic system is going to be a little toxic. Please do not slip off. I'll try to make it as simple as possible, right? So start off. Yeah. Hippocampus and limbic system, they are part of the temporal lobes. And to understand the anatomy, we need to basically understand first the function, what it does, and then we'll go to the little bit of a anatomy of the temporal lobe proper, and then go dedicatedly to the hippocampus and the limbic system. So the temporal lobe plays a very key role in our cognitive functions, basically like creation, retrieval, and consolidation of memories, special navigations, as how you go from Nair to your house, or how do you go to from Nair to Maratha Mandir and whatever. Emotions and social behavior. How do you behave in the class? How do you behave on the road? How do you behave in the society? So temporal lobe, the hippocampus, and the limbic system plays a very important role in doing this. So now coming to the brief about what is temporal lobe. So the temporal lobe is divided by 5 cell size. Basically, there are 3, 2 on the lateral, 2 on the inferior, 1 on the middle side. The temporal surface, it 4 cell size, and it divides. I'll show you the images also. Let me show you that will be better. Okay, so you can see from this image that this is the Sylvian fissure, what you are seeing here. This is the gross anatomy, then we'll go into the MR anatomy. This is the Sylvian fissure here, and this is the superior temporal or the first temporal sulci. Between these two is a superior temporal gyrus, right? Between the first and the second temporal sulci, there is a middle temporal gyrus, and below it will be the inferior temporal gyrus. The superior temporal gyrus continues posteriorly into supramarginal gyrus, which is this. You can see the white arrow. It continues like this here. The middle temporal gyrus continues behind with the angular gyrus, and the inferior temporal gyrus continues behind in the inferior occipital gyrus. This is on the lateral surface. Now coming down to the inferior surface, there is a fourth convolution called occipito-temporal gyrus, and there is a small collateral fissure. Okay. This gyrus is called temporo-occipital gyrus, and this is called a lingual lobule, which the parahippocampal gyrus continues behind. So this is a written part of it. Now this is the MRI, how it looks. For the temporal lobe anatomy, we usually perform a MRI in an oblique coronal plane perpendicular to the hippocampal and the parahippocampal gyrus. So coming to this, this is the first superficial temporal gyrus. This is the middle temporal gyrus. This is the inferior temporal gyrus. You can see this arrow. This arrow is collateral sulcus. This is the temporo-occipital or subcollateral gyrus. And the second arrow, white arrow, what we have been labeled is parahippocampal gyrus. Okay. So the parahippocampal gyrus is laterally cut short by collateral sulcus or margin by a collateral sulcus. And on the left-hand side, if you can see here, the thing which is highlighted in the pink color is the hippocampus and the parahippocampal gyrus. Medial to that it will be an ambient system. Okay. So this was what we have seen, the lateral and the inferior surfaces of the temporal lobe. Now coming to a more important medial or mesial temporal lobe, which is the more or less the primary site, or there are high chances of lesions which are causing epilepsy in humans. 70% of the epilepsies they arise from the temporal lobe. So to understand and once we know the anatomy, it will be easier for us to come to image the image on MRI and pick up the pathology. So mesial temporal lobe is a part of the limbic system. So I will start off with that. The first will be the parahippocampal gyrus. Second will be the uncus. Third will be the hippocampus. Fourth will be the fimbria, dentate gyrus, and amygdala. These are the part of mesial temporal lobe, which basically and indirectly they are part of the limbic system. So what is parahippocampal gyrus? So parahippocampal gyrus is a gyrus which occupies a space between the inferior and the medial surfaces of the temporal lobe, and it extends longitudinally along the tentorial leaflet. So I'll show you on the images also. So it's along the tentorium and it makes contact with the ambient system as what I just showed you. This is the ambient system. So you can appreciate this is the parahippocampal gyrus and this is the ambient system. Okay, so the extend, okay, anteriorly at the anteriormost end it turns medially and posteriorly, which forms the uncus, and this uncus has a very important component which is called entorhinal cortex. The parahippocampal gyrus itself, as this is the anterior aspect. Now coming to the posterior aspect, the calcarine fissure divides the parahippocampal gyrus into a superior component and an inferior component. So let me show you image. Okay, you can see this. This is the green, the parahippocampal gyrus. This is lateral aspect. Is divided into two parts. The superior, which continues with its isthmus, goes above and connects with the cingulate gyrus. This cingulate gyrus will go loop around the corpus callosum, comes into the subset in the septal area and ends here. Okay, this area is called septal area, and then the inferior portion will continue as the lingual gyrus of the occipital lobe. Okay, so this is lower. Laterally, it is limited by the cholesterol sulcus, what you can see on a coronal plane. Okay, this is how it looks on MR. You can see this parahippocampal gyrus out here, when marked by a blue arrow. This is the MRI T2 weighted imaging. I'll come on T1 and T2 little later ones when I show you the proper. These are the static images. I'll show you the dynamic DICOM images also for this. Okay, so the parahippocampal gyrus, it has two components, very important two components. One is subiculum and one is the entorhinal area. The subiculum is the medial and the superior edge of the parahippocampal gyrus, and it connects to the corneo-ammonis or an ammon horns. Okay, and entorhinal area, or what we call is Brodmann's area 28. It's not a well demarcated. You can say that this is entorhinal cortex, but it's a diffuse area which it's located in the uncus. I'll show you on the little later on to the images. So the next part of the the limbic part would be the uncus part. The uncus is formed by the anteriormost part of the hippocampus, and it is functionally divided into two parts. The anterior part belongs to the parahippocampal gyrus, and the posterior belongs to the hippocampus proper. Okay, so now I was just telling you about the subiculum. So this is the hippocampus. This is, if you can see, this is the temporal horn. This is in the coronal plane. We are cutting the brain in a coronal plane. This is the parahippocampal gyrus, and it turns like this laterally. The first part what you hit would be a subiculum. Okay, subiculum will continue with corneo-ammonis, which is 1, 2, 3, 4, and then down below would be a dentate, gyrus dentate. Okay, a small thin line what you are seeing out here is called alveus with a fimbria, which thickens medially and forms a fimbria. Coming to the next part of it is the hippocampus. So the cerebral cortex is usually made of 6 cell layers, neocortex, while the medial temporal structures are formed of primitive allocortex, which can be, depending upon the area, can be 3, 4, or 5 cell layers. It begins in early life as a flat plate-like structure along the medial wall of the floor of the temporal horn, with the hippocampal infolding, which results into characteristic interlocking C-shaped interlocking configurations. Okay, so the hippocampus itself is arbitrarily divided into 3 parts: the head, body, and the tail. Talking first about the head would be the head itself, it's the most anterior part of the hippocampus, and it is the most voluminous. The body and tail are not that big, but the head is more voluminous, and it's further divided into the intraventricular component and the extraventricular component. The extraventricular component is nothing but the uncus. The intraventricular component is what we see those digitations on MRI or on the images. Those are called intraventricular. They are called sulci, small sulci divided by sulci, and this is believed that it came about as a result of obstacle to the forward development of the hippocampus. Okay, a good number of people, the head of the hippocampus would be fused with amygdala. The hippocampal body again is divided into two divisions, like the intraventricular and extraventricular component. The intraventricular part corresponds to the depth of the C1, CA1 and CA2 field of abdominal hulls, and extraventricular part is the medial surface and is made up of dentate gyri, fimbria, and superficial. Okay, now I'll show you on the images, right? So what you are seeing out here is a subiculum. Okay, this is the parahippocampal gyrus. This is the collateral sulcus. Okay, it will come in like this, subiculum. Then here it's slightly more bulkier than the either side, and this becomes a CA1, CA2, CA3, CA4, and the blue one is the dentate. Okay, this, what I'm showing you, this is in the coronal plane. If you see this white thing, this is a T2 weighted images where the fluid is brighter. So this is a temporal horn like this. Just below the temporal horn, you can see a thin line which is coming out here like this. That is the alveus, that is the white matter. Medially, it goes and forms the fimbria. And this is the choroid plexus, right? Coming into the sagittal plane, how it looks. The entire length of the hippocampus is around 4 centimeters, 3 to 4 centimeters. And again, as what we have seen, it is divided into 3 parts. This part is the uncus. This part is called the amygdala. This is the uncal recess. And this is the head. The minute you start seeing the choroid plexus, that is the junction between the head and the body of the hippocampus. So in this particular image, if you can see, the red one is the choroidal plexus. So, and the green vertical line, what has been drawn here, that would be anything anterior to this would be head. Posterior to this will be the body, and the part which curves upward will become a part of the tail. This is the high resolution 3 Tesla MR images, which I don't expect you to be able to know, but this is, I'm just telling you. But there's a schematic diagram present explaining the entire what I just spoke. So parahippocampal gyrus, subiculum, CA1, 2, 3, 4, dentate gyrus. The blue line, what you are saying is alveus, which forms the fimbria. Okay. Again, MR images, if you can see, this is the, more for the anatomy people, this is hippocampal for, I don't know the staining part of it, but what we can see out here is you can see the amygdala. These are the multiple digitations of the hippocampus, and then what you can see here is an uncinate gyrus. This is how do you recognize this hippocampus on an axial plane? So MR you can take in axial, coronal, and cell, whichever way you want to plan it. So the importance of how do you divide the hippocampus on axial plane? What we are seeing out here, these are 2 dotted lines, and this is the interpedicular cistern. So the line drawn at the posterior end, anything anterior to it would be a hippocampal head. Anything behind the tactile plate would be a tail, and between the two would be a body, right? This is how it looks in the sagittal, oblique sagittal plane. Okay, so amygdala, head, body, tail. The dark line, this is T2, so white matter would be dark on T2. So you can see out here will be the alveus, and this is the uncal recess, the red arrow, right? Okay. So as we progress in a newer magnets and higher strength magnets, at present the FDA has allowed a 3 Tesla MRI, but maybe in near future we can get a higher end MR where we can really differentiate the layers of the hippocampi. And this is one of the example. This MR is done on a 9.4 Tesla MRI, which is more of a research or a research oriented MRs. What we see, they are not commercially available for a human use. And on the right hand side, this is Nissel stain specimen, right? So again, coming to that, the subiculum part, okay, the CA1 continuing here, it arches laterally like this, CA1, this all the way up till here, this is CA2, again CA3 and CA4. The CA4 and the dentate nucleus is good number of times are not seen separately from it. And on this MR, if you see, you can label this multiple layers of cells. You can see here 4, 5, 6, 7. These are all multiple layers of or what can say the cells of hippocampi. So what we call between this is stratum pyramidale, stratum pyramidal, stratum radiculata, stratum lanconism, stratum follicular. These are multiple layers of cells which we can see on MRI. But this is on a higher Tesla MRI. The same thing what we are seeing on MR, we can, or I would say the same what we are seeing on histology, we can see it on MR. And if you see here, the subiculum is much more thicker in this particular region. And this is the junction of where it becomes thin and joins the CA1, right? What we are seeing out here is the lateral geniculate body. This part, this out on MR is a lateral geniculate body. This is the arterial supply of a hippocampus, which is supplied by the posterior cerebral artery. So it has three, the anterior, middle, and posterior hippocampal arteries, which supply the entire hippocampus. So any infarct in the posterior circulation, if it reaches here in the smaller branches of PCA, can lead to an infarct or a restricted diffusion on MRI. Now coming to the important component of this thing is again stressing on subiculum is it's a trilaminate cortex composed of superficial molecular layer, central pyramidal layer, and deep polymorphic layer. The subiculum itself is divided into multiple areas. Lateral to medial would be prosubiculum, proper subiculum, presubiculum, and parasubiculum, and it continues into the entorhinal area. Usually you don't see these structures on MR. It will be seen on histology, but it is not seen on MR. Okay. And the white matter of the parahippocampal gyrus, or what we call, is an angular bundle. So I'll show you on the image what I'm trying. Yeah. Okay. So again, superior temporal gyrus, middle temporal gyrus, inferior temporal gyrus. Okay. Collateral sulcus, parahippocampal gyrus, and the hippocampus proper. The zoomed image again you can see is the subiculum, and then you can see all the layers out called what we call is stratum. Just now, SRLM is the short form of it, and it continues as CA1, 2, 3. This dark line, what you are seeing is the alveus, which continues here as a fimbria, and fimbria will connect into the fornix. Okay. So this is the another slice of MRI which shows the hippocampal. This is the hippocampal head. Okay, hippocampal head region, where you can see this is semilunar gyrus with and this is the ambient gyrus with. This is the uncus part, which is the most medial aspect, is formed by semilunar gyrus and an ambient gyrus here. And then you have an SSA, it's called sulcus semilunaris. Okay, so this is the MRI where what we have done is an oblique MR, where you can see the uncus out here. This is the amygdala. This is the hippocampus. Out here would be your fornix, which forms and loops around anteriorly. This is the LPS. Again, I have already shown you. Again, I'm showing you this. Okay. Now, coming to the fornix, what is fornix? Fornix is the main efferent fibers for the hippocampus. All the major fibers, they would usually arise from the subiculum and from the cornu ammonis and possibly from the dentate gyrus, and it is spread along the ependymal, subependymal ventricular surface. Okay, so fimbria increases the thickness posteriorly and it forms the crux. Let me show you that. Okay, so what you can say is this is from here, the fimbria will continue posteriorly, come here, forms the crux, loops around superiorly from both the sides, joins in the midline to form a commissure. Few of the fibers would cut across each other and then it forms the body. Body will come at the level of the foramen of Monro, just anterior to the foramen, posterior to the foramen, interventricular region. It divides into columns, which is seen here. The columns would be dividing into a pre-commissural fiber and a post-commissural fiber. These are the MR images. Hope I have covered. Okay. So I'll show you on the when I show you the dynamic image, I'll show you the fornix also. So on the sagittal plane, what you are seeing is this is the fornix, this is the corpus callosum, what we are seeing. This would be the septal area. This would be your mammillary body, and this is the anterior commissure. This would be the post-commissural fibers of the fornix. So the pre-commissural fibers, they usually arise from the subiculum and the cornu ammonis, and the post-commissural fibers are arising only exclusively from the subiculum. This then it will be passed to the mammillary body and then into the thalamic nuclei and midbrain. Septal area is a very important component of the limbic system, and it is divided into gyrus and parahippocampal gyrus. Let me just, okay. So this is a sagittal flare images of the brain, with the area what we are been arrowed, it will be the septal area. Okay. This is where your the cingulate gyrus will come. You can see out here the cingulate gyrus can come and it ends up here into the septal region. Mammillary body will receive and transmit information from hippocampus, septal nucleus, and hypothalamus to the anterior thalamus via mammillothalamic tract and to midbrain via mammallotegmental tract. Amygdala again is a large nucleus which belongs to the olfactory center and partly to the limbic system, and it is responsible for a fight and flight response in you. Okay. So these are the various arches what we see on MR. This is the if you see out here, this is the parahippocampal gyrus, which is containing with the isthmus into fasciular gyrus and continues in the cingulate gyrus. Down loops around the corpus callosum and ends into the preseptal in the paraterminal gyrus. This is the hippocampi, which will continue into an inducent gracium and again ends into the septal area. This is the fornix, the dark line, which will continue and it goes below the corpus callosum, ends into the mammillary body. So these are the curves of limbic system, what we see, and this is how everybody must have heard about the Pepys circuit, how it functions. So let us say it starts from here, the entorhinal cortex to hippocampus. From there it goes through the efferent outloop into the fornix, into the body, comes to the column and into the mammillary body. From mammillary body, it goes to the thalamic nuclei, anterior thalamic nuclei. From there, it goes into the cingulate, and this dotted line again shows that through the cingulum, it comes back into the parahippocampal unit, the anterior rhinic cortex. This is the Pappage circuit, what is been described. So, the anatomy is important because if we don't know, then we will not be able to pick up a normal versus abnormal. So if you see this is a normal horizontally placed hippocampus, while on the left hand side, it is more vertically placed hippocampus. This could be the cause of seizure. Okay, so you have to pick up this. There are other commoner things what the hippocampus is involved, something called mesial temporal sclerosis. So if you see on the left hand side, which is abnormal, this is bright on flare and atrophied, compared to the right side, which is normal in size and it's not showing me any abnormality, signal abnormality. So this is mesial temporal sclerosis is a very important, one of the very common and important cause of seizures. Once the patient has a seizure, not every time you would get a atrophy of the hippocampi or there is signal abnormality. This is just a simple, the hippocampi are showing me diffuse white hyperintense signal with restricted diffusion, which shows that this is just post-ictal change. He had a seizure and we have imaged him within 2 or 3 days. So these changes are, you can really pick up on MR. There is no atrophy, so we will not call them as a mesial temporal sclerosis, but definitely post-ictal change. This is herpes encephalitis, which involves typically the medial occipital and bilateral asymmetrical. Limbic encephalitis, as what we see. Alzheimer's, where typically the hippocampus gets atrophied, the medial temporal lobe gets atrophied, and there's something called MTA scale where we tell them the amount of atrophy and the hippocampal atrophy. Common tumors, what we usually see in temporal lobe is ganglioglioma, DNET, and PXA. This is diffusion weighted imaging, what we do on MRI, where we can pick up infarct as early as 10 minutes or maybe less than that. So if a patient typically presents with a posterior circulation infarct, so we can really say this is a thalamic infarct with hippocampus. So posterior circulation stroke can be, once you have a posterior circulation, you are supposed to see that. This is the occipital pole where the infarct is being seen. So entire posterior circulation is infarcted. The patient can present with a transient global amnesia. So the hippocampus is the area which gets involved in that. And we can pick it up on MR. You can see those bright dots on diffusion weighted images. So this is what we see on, it's called transient global amnesia or TGA. Carbon monoxide poisoning can involve the hippocampi. Hypoglycemia can give you hippocampal involvement. And now just few points which you need to really remember as a clinician or for a student is 70% of the cause of epilepsy is seen originates from the temporal lobe. CA1, what I have been stressing about, is the most vulnerable for ischemia. CA3 is the most resistant area, and CA2 is basically involved in Lewy body disease. Okay, these are dementias, and Lewy body disease can cause the atrophy of CA2. It's not routinely seen on an MRI, but we need to, once we have a higher strength MR, we can really pick up all these things. These are the references. I want to change the. ये करो. Okay, so coming to the real, the MR, what I've been talking about. This is a T2 weighted images of the hippocampus. And if yeah, so I told them I'll tell them. So basically, a T1 weighted imaging is basically used to see the normal anatomy of the brain where your CSF is darker. Okay. On T2 weighted imaging, you usually see it when the fluid to be brighter. Okay. And T2 is used to pick up the pathology. T1 is used to pick up the when to see the normal anatomy. That's the basic of it. Then there are multiple sequences, but let's not get into MR. एक ही चाल।
दोनों से एक चालू करिए।
ओके, दोनों ये बंद करो, ये दो ठीक है, चलेगा।
Zoom में जाके start sharing events.
देखिए
Start share.
मैं दो विंडो एक साथ नहीं खोल सकता।
हाँ, एक करके एक कर। डबल
यार
लैगिंग है 1 मिनट का इंटरनेट। हेलो
या ओके आई कैन नॉट स्प्लिट द स्क्रीन। मेरे उसमें स्प्लिट, ये इसको मैं स्प्लिट नहीं कर सकता।
सर एक बार दूसरा स्क्रीन शेयर करके दिखिए।
नहीं नहीं, ये एक साथ दो कट में
उसका देखो ट्राई करिए। विल सी हियर वेट टू परसेंट 30 to 60 सेकंड्स लैग होता है।
दूसरा नहीं आ रहा है,
स्क्रीन
एक ही आ रहा है। ओके, आई नीड टू चेक। ओके,
स्क्रीन करके एक बार ट्राई कर आंसर ठीक है।
आई विल मैनेज, आई विल मैनेज। forget it, forget it. I'll toggle. So this is a T2 weighted imaging. This is what we have been talking about. So this image is acquired when you take the oblique coronal. It's not straight coronal, it is oblique coronal perpendicular to the, so let me tell you. Yeah, okay. So in the sagittal plane, what we are seeing is this is the hippocampus. So the way we acquire is in this direction, perpendicular to the hippocampus, and that will give us the precise anatomy on coronal plane. So coming from anterior posterior, if you can see this on MRI, the superior temporal gyrus, the middle inferior temporal gyrus, you can see the collateral sulcus out here, beautifully here, this one. This is the interdigitations, what we are seeing of the hippocampus. This is the uncinate gyrus. Okay. And once we go from this, starting from anterior, again, this first would be the head, which is the most voluminous part. Coming to the bed, we have started seeing the choroidal plexus. So this would be the body. Going behind the body, when it is arching out here, you can see that thing coming out, this track which is coming out here. Yeah. So keep an eye on this. You can see this coming out here like this. So that is the fornix. There is a crura of the fornix which joins in the midline. Here it is joining this part. It joins in the midline to form a crux, and then it then forms the body. As it goes anteriorly, I cannot hear you. Okay. You can ask me later. Let me just finish. So this is the body. Coming anteriorly, it divides into two parts into the columns. This part, and then it divides into this ends into the mammillary body. This is the mammillary body here. These two, you can see those two bumps. This is the mammillary body. Now, coming onto the sagittal plane, again you can see this. Superior temporal gyrus continuing behind into the, which gyrus it will continue? Supramarginal, right? Then you can see the middle temporal, which is continuing behind into angular gyrus. Then let us see the parahippocampal gyrus. So this is hippocampus. This is hippocampus. Going more laterally, this would be the parahippocampal gyrus. It is dividing into two. The superior one will continue as a isthmus and continue into cingulate gyrus. The inferior one will continue into occipital. That will be a lingual lobule, right? So this is the parahippocampal gyrus. Okay. Now the arch is what I was trying to show you on the. Just keep a track on this. I'll show you the right here after the superior aspect out here. If you just see behind, it goes behind the. This is the corpus callosum, what we are saying. Above that would be your cingulate gyrus, which is coming down like this. Cingulate gyrus will go, better seen on this. Cingulate gyrus will go in like this and end into the septal area. This is the corpus callosum, and this is the rostrum of the corpus callosum, which the entire cingulate gyrus will come and end in here. Okay. Then if you okay. Yes, I'll come there. Okay. So the black, this line you can see, that is the temporal horn. This is the hippocampus. You can see this white line which is going above. That is the alveus, which continues medially and thickens to form the fimbria. Fimbria will continue posteriorly. Here you can see this beautifully. And it will continue below the corpus callosum and join in the midline to form the crux. Then it will form the body. And then in the midline, it will form the column. And then it will end into the mammillary body. So the entire anatomy you can see on sagittal plane, right? You can, this is the septal area, which is very important for the limbic system. And if you can see these two gyri, these are vertical gyri. They are called paraterminal gyri. And this bright dot you can see, this one what I'm putting my cursor on this, that is anterior commissure. So all the nuclei of the paraseptal are positioned in anteriorly, posteriorly, and superior to the anterior commissure. So your entire relay would come from all this circuit into this area, from their mammillary body, mammothalamic tract, and then coming back from that into the cingulate cingulum and back to the hippocampus. That's how the anatomy and physiology works. This is a T2 weighted high resolution 0.9 millimeter cuts. We can go to 0.6 millimeter on a MRI, but usually 0.9 millimeter cuts, which will give you a volume sequencing, and we can tell you about the volume of the temporal lobe. We can tell you the volume of the hippocampi. There are other modalities where you can say that the right temporal or the left hippocampal, they are atrophied, and that can help in making a diagnosis. I forgot to show you the inducium gracium and the hippocampus. Okay, so this is the hippocampus here. This part will continue along above a gray matter which continues above along the single corpus callosum and continues here along and again ends into the same septal region. So you have 4 arches. Going back to that image, मुझे वो change करना पड़ेगा. मुझे वो PPT. PPT. खुला हुआ है. Okay. Okay. So again, coming back to this image, what I showed you just now on MR, we can just have a quick revision and then we'll finish it off. So parahippocampal gyrus, the inferior going into the lingual, the superior going through the isthmus into the cingulate gyrus, coming and ending into the septal region. The gyrus, dentate gyrus going behind. It's a gray matter which is along the corpus callosum, forming inducium gracium, going again and ending into the septal region. This is the fornix, the white matter outflow tract going into the fimbria. From here, fornix, body, column down into the mammillary body. So this entire circuit form, this entire area, starting from the hippocampal, parahippocampal till the septalia, they are part and parcel of the limbic system. So these are the books one should read if anybody is interested in MR and a limbic system. Thank you. I hope it was not boring or putting off to sleep.
Thank you very much, Dr. Rahul. I think it was inspirational and more, I would say, inducing their interest so that the students who are now learning, we've just started our neuroanatomy lectures. So I think about 4 or 5 lectures, 5 or 6 lectures have been completed. So with this overview of limbic system, and how it is important and how it is radiologically seen in images, it will help you in generating your interest and wanting those of you who are already interested in it, your interest will be deepened and your focus will now shift from learning, rote learning to understanding and learning. So I think these lectures that we've done from morning till evening, it's now almost 4 o'clock, yeah. So I am